There we go. All right. I am Erin Zepezauer. I am the nurse practitioner in the Orthopedic Bone Health Clinic and also part of the Fracture Liaison Service at Freighter and the Medical College of Wisconsin. Today, I will be discussing the FLS workup and when to refer. So, um, essentially, I think the importance of this talk is to make everyone aware of the capabilities and limitations of the FLS. Because we're not always that well known by everybody, not as well known certainly in the osteoporosis world as, let's say, endocrinology is. I have no relevant disclosures. The objectives, I'm not going to go through all of them, but our Freighter and Medical College of Wisconsin FLS model, we have an inpatient FLS coordinator, Sarah Arndt, who sees all of the fragility fracture patients who come into the hospital. She, a lot of times, kind of handpicks the patients or determines who needs to be seen because we don't always get the referrals that we should be seeing. So Sarah's really great about finding the patients that need to be evaluated. As I said, I am the outpatient FLS coordinator and also run the bone health clinic. Our collaborating physician is Dr. Schwab, and our endocrine resource and support is Dr. Shaker, who without him, we really, I think, would be lost. So we really appreciate everything that he does for us. So there are a few different FLS models, but with our model, we see the patient after fracture and we follow them through until we initiate treatment if that is appropriate, and then follow them after treatment is initiated. So some things to consider with FLS and the different workups that can be done. One of the main things is there are different models of the FLS. Some just identify patients and then let the primary care physicians know that the patient has fractured and needs to be treated or needs to have a bone density scan. And many FLS clinics are independently run by advanced practice providers with a collaborating physician who specializes in orthopedics. So that can sometimes be a limitation in that we don't always have somebody in clinic with us who can immediately answer questions on certain patients or certain cases. And the workup can definitely differ between fracture liaison services based on experience and available resources and support. When I first started this position 3 years ago, my workup is similar to what I used to do, but I have broadened it much more than where I was previously, and I tended to refer more frequently than I probably needed to at that point. So when we initially started the FLS, we had sat down with endocrine, and they helped guide us with what labs we should check on all of our fragility fracture patients. So we initially check an intact PTH, a CMP, CBC, a MAG, a FOS, protein electrophoresis, TSH, and a 25D. Ideally, in hip fractures that come into our emergency department, they will have these labs drawn prior to having surgery, right? And they'll have them drawn right in the ED, which helps us get them treatment in a timely manner in an outpatient setting. And then depending on those initial labs, and also depending on the patient's assessment during their clinic visit, I'll usually add on a 24-hour urine for calcium and creatinine if it's feasible. A lot of our patients have mobility issues, so it isn't always something that we are able to do. We'll screen for celiac disease, we'll go over or look at late night salivary cortisols in patients who we are suspicious of Cushing's. If there's any, alkaline phosphatase levels in these fracture patients can be somewhat tricky because we expect the alkaline phosphatase level to go up after fracture. So it's really helpful if we have levels to trend from prior to the fracture. But if I trend back and somebody's had elevated alkaline phosphatase levels or low alkaline phosphatase levels, I'll usually check a bone-specific ALK phos, alkaline phosphatase isoenzymes, or if I need to differentiate between bone and liver, I'll get a GGT as well. C-telopeptide is another lab that I don't check it in many post-fracture patients. I usually save it for those patients who their medical history isn't all that reliable. They think they were taking a bisphosphonate in the last year or two and aren't quite sure. Then I'll check a C-telopeptide, but it's not very frequent. If there's hypercalcemia, we'll check an ionized calcium. Occasionally we'll check a 125D or a PTHRP, and testosterone in some of our men. Imaging is an important part of the workup. On all of our fragility fracture patients, we try to get a VFA with our bone density scan, and also a TBS. Not all of our scanners have a VFA, so if the VFA is not available, then we follow the ACE guidelines as far as for when spine imaging should be completed, and that is if the T-score is less than a -1.0 and one or more of the following is present: women greater than age 70 and men greater than age 80, historical height loss of greater than 1.5 inches, self-reported prior vertebral fracture not previously documented, or glucocorticoid therapy equivalent to greater than or equal to 5 milligrams of prednisone or equivalent per day for greater than or equal to 3 months. So a lot of my patients qualify for spine imaging. So it is really helpful when we can get VFAs on those patients. And then this is rare also, but occasionally we'll get femur films if there's a patient with a history of a long-term bisphosphonate use and thigh or groin pain present. So this is my personal experience as far as when I refer. There are certainly things that I will refer for in the future that I haven't necessarily come across yet in my clinic, but these are the most common reasons that I refer. So these are cases where I refer and then I hand off care. So I'll refer to endocrine if the patient has an elevated intact PTH with no obvious secondary cause. I learned early on that a lot of our patients will have elevated intact parathyroid hormones because they're so deficient in vitamin D, have low calcium intake. So I've learned to become a little bit more patient, and I will recheck the PTH a few weeks after they've been on adequate calcium and vitamin D. And if it's at least moving in the right direction, then we can consider putting them on treatment. But if it's not budging, then I'll usually send them to endocrine. If the patient has low alkaline phosphatase levels, hypercalcemia, hypocalcemia, or hypo or hyperphosphatemia. And then I will refer to oncology if we have a case of a suspected myeloma. And then there are also instances where I will refer a patient to a specialty practice, but then continue to manage their osteoporosis in the FLS clinic. And so these would be things that I find like in the workup or in past medical history. I usually try to do a fairly thorough chart review, look at past imaging. So if I find a new hyperthyroidism or a new hypothyroidism, I usually will send to endocrine. If it's hypothyroidism, a lot of times I'll just message the PCP to see if that's something that they will be okay with managing. I will send to endocrine if there is a history of an adrenal nodule that has not been evaluated, a history of a thyroid nodule that has not been evaluated, elevated salivary cortisols. I will send those over and then treat the patient if appropriate. And then recurrent kidney stones, we'll send to the stone clinic, but I'm cautious about starting treatment, before the patient is seen necessarily. If they have the 24-hour urine stone panel completed, then we could maybe consider treating, but I prefer that their workup is done in the stone clinic before treating. And then if somebody has positive celiac antibodies, we'll send to gastroenterology. If the patient will go to benign hematology if they have a monoclonal protein, and we'll wait until we hear back from benign hematology to initiate treatment. And if on the lateral spine films we find an acute compression fracture, then we'll send the patient to spine care to be seen. So just going over a case that I saw a couple of months ago, relevant to the workup. So this was an 84-year-old female with a left femoral neck fracture after a fall. She was found down after an unknown amount of time, but her last known well was 48 hours prior to that. She was seen in the hospital by our Fracture Liaison Service. So when she went to the emergency department, they unfortunately didn't check all of her lab work at the time, but she clearly had an acute kidney injury, creatinine 6.14. Her calcium at the time was 8.9, but corrected to 9.8. Alkaline phosphatase was on the low normal end, and she had a low H&H, low platelets, 25D was fine, and her TSH for her age was okay. She had a TFN after she was medically stable, and she was discharged to rehab. The FLS coordinator on the inpatient side did her initial assessment, ordered DEXA with a VFA, and set her up to follow up in clinic. So I saw her in clinic about 6 weeks after her fracture. She came to clinic taking 600 milligrams of calcium carbonate BID. That was not something that we had initiated the patient on. They came from the SAR on that. And then she was on 2,000 units of vitamin D3 daily, also taking citalopram and levothyroxine. Her last bone density scan was in 2016. She had her lowest T-score was a minus 2.0 on the right total hip. She had not yet gotten her the bone density scan that was ordered for her by the FLS. And then in her review of systems, she had weight loss, fatigue, decreased appetite. We had the patient schedule the bone density scan and get additional lab work done. When her labs came back, her intact PTH was 10.6, calcium was 11, but 11.7 when corrected for the low albumin, and her creatinine was 1.17. So at that time, we didn't have the protein electrophoresis back yet, but once I saw these initial labs, I did add on the light chains, and the free kappa was elevated, and kappa lambda ratio was also elevated, and monoclonal bands were present. And I did recheck the labs just to confirm and to see where her ionized calcium was. After that came back, her intact PTH was 8.8, the ionized calcium was 1.63, Calcium was 12.3 corrected. So I placed an urgent referral for the cancer center after undergoing a bone marrow biopsy. She was diagnosed with plasma cell myeloma, and she received a dose of Zometa, but is declining further treatment. So this case was interesting to me because she wasn't, prior to being admitted, and the whole time she was admitted, her calciums were seemingly normal, but even before that, her calciums historically were normal. We didn't always have albumins to correlate, but just interesting because a lot of times when we think of myeloma, we think of spine fractures. So she had the hip fracture, so a little bit different of a case.
4 minutes.
And that is all that I have, and I will take questions.
Perfect. Thank you very much. It was a very nice talk. We do have a question. I'm curious about checking SPEP on all patients, even those without anemia, hypercalcemia, chronic kidney disease, etc. Any guesses about how often you found a meaningful result when there was no other signal for myeloma?
Yeah, that is something that that we've gone back and forth about with, do we check, do we not check? And it was decided that on any of our, on any fragility fractures, we would check an SPEP. Also because if they do have an MGUS, we would probably want to avoid a PTH analog. So that's where my thought is, but that is definitely a consideration that we've talked over before.
Dr. Shaker would like to make a comment.
Well, first I want to respond to the other question. I agree completely with Erin. You find a lot of MGUS, and I think there's data that shows the risk of MGUS in patients with osteoporosis is significantly higher than in the general population. And if someone has an MGUS with 0.5 grams, I am very reluctant to use teriparatide or abaloparatide. And some of these very insignificant ones are one thing, but some people have significant MGUSs, and it's pretty common. So I think if I'm considering anabolic therapy, I'm definitely going to do an MGUS. But the comment I want to make is Erin, Erin and her team do a great job, and I can't tell you how many patients she's evaluated I know there's at least a couple adrenal Cushing she's picked up. So I think it's the attention to detail that really makes a difference in figuring out some of these things. So I want to thank Erin for all the work she does, because it really does improve access in our system. And I think everybody else can probably echo the same thing, that access.
Yeah, thank you. Thank you.